of the WPS Advocacy webinar series. This is a little bit unique, and Maryland is the only jurisdiction that WPS represents that has where we have a joint committee, and we meet actively during the legislative session. And we're here with us tonight is our special guest, Cynthia Major Lewis, who's the co-chairman of the Legislative Advocacy Committee, and also Gabe Terry, our primary lobbyist. And unfortunately, Gabe's only here for a few minutes, so if anybody has any pressing questions about they want to ask the lobbyist, now's the time to do it. So that's that. As the old saying goes, if you're not at the table, you're on the menu. And I think this saying is very relevant to psychiatry. It's essential that we as members of the profession actively advocate for ourselves. So we have two goals tonight for those of us who are here and those of us who have been watching the video. And the one is to tell you about the work of the Advocacy Committee, and also to inspire you to get involved, either by joining us. Certainly WPS would love to have our members on our own individual Legislative Advocacy Committee, or also by reaching out to your local legislative representatives. Our LAC took its current form in the fall of 2020 when NPS and WPS concluded, after a long discussion, that the interest of all our members would best be served if members of WPS would join the NPS Legislative Action Committee to form a joint committee. So even though we're two different organizations and don't always agree, we've developed a mechanism to resolve these disagreements, and we've been through it a few times, and each time it's gotten more and more harmonious and quick to come to a resolution in a time frame that's necessary with these fast-breaking legislative events. The legislative session is only 3 months long. Lots of bills drop, and our lobbyists do a very, very good job in picking those bills that are of relevance to us. And the committee, over the years, primarily NPS, has developed a very sophisticated mechanism whereby these bills are reviewed throughout the week, and there's sort of asynchronous discussions on a message board where people express their opinions, have their, so that by the time we get to the meeting, we're able to really efficiently go through the discussion. And we're also always looking for opportunities to work proactively and introduce bills of our own. In fact, it was our committee that drafted an ambitious first version of a bill to reform prior authorization, as one of the attendees is well aware. And it's interesting, after much discussion between the medical community and industry, a bill was passed in 2024. It started with us, but the final form wasn't quite as ambitious as what we'd hoped for. But still, it was a start. And maybe later tonight, if we have time, we'll talk about what the latest developments on that front are. So that's that. So I guess right now, if there are no questions for Gabe, we can invite our special guest tonight to talk. This is Cynthia Major Lewis, MD. She's the co-chairman of the Legislative Action Committee, and she's also the chief of psychiatric emergency services at Hopkins. She attended Howard University and Meharry Medical College, trained at Hopkins, was the first Black female chief resident there, and in her work in the emergency room, she became galvanized by what she saw as a revolving door of people coming in and out, committing people, leaving, and coming back in just as bad shape, and that sort of led to her getting becoming an effective advocate for treatment of the mentally ill. So, and she'll tell us more about her work with getting the AOT bill passed. So anyway, let's invite Dr. Major Lewis to join us. So,
hi everyone. So happy to be here. Thanks, Dr.
Okay. So let me ask you a question. Did you know when you first became a psychiatrist that you'd be so involved in the advocacy process?
I think, like all of us as physicians, I think we all know that we come into this work because we really want to help people. We want to be a voice for people. Given what we do with our patients, we know a lot of our patients are vulnerable. So I think, I knew that I would be advocating for, medications or for treatment, but it really was not until I was embedded in the emergency department in 2019 that I really realized there was only so much that I could do from the front lines or from being within the walls of Hopkins. And I realized that if I wanted to really affect some change, that I was probably going to have to you know get outside of Hopkins and probably get involved with the people who make the laws. That didn't come to me on my own. I will say a little bit of my background was I was a community psychiatrist for many years, for about 15 years here in our community psychiatry program at Hopkins. There, we had social workers, therapists, psychiatrists, we had inpatient units, we had our emergency department, we had a day hospital, and we treated really ill patients, but I felt like we did a really good job doing that. And I do remember that we would lose about 10% of them to like mobile treatment because they were a little bit more disorganized, needed more support, needed targeted case managers. And so I knew we would get them to mobile treatment. They would usually do well. But it really wasn't until I was asked to be embedded in the emergency department as the attending psychiatrist in 2019 that I realized that there was a population that I wasn't even aware of. This population that pretty much lived in the emergency department. I would see them multiple times a month. I would either hospitalize them, typically voluntarily. They would come into the hospital, and then a week later, I would see them back in the emergency department. So for me, I was advocating, and I said, okay, something's wrong here. Why am I seeing these patients as much as we are? I started reaching out to my mentors to find out, okay, what can we do? I thought maybe do we need state hospitals to kind of open up beds because these patients are failing? And then I realized I couldn't just admit people to state hospitals. So that started my journey. I started reaching out to my mentors and I said, what can I do? And they said, you really have to, one, join MPS's legislative committee. Because if you want to really affect real change, you're probably going to have to, get in front of the legislators and start talking about changing laws. So that really began my journey of I joined the committee in 2022. I learned that the AOT bill was coming up for like a couple of decades. And then I realized that we weren't even supporting it for our various reasons. And that really started me on this kind of 3-year journey that eventually in 2024, after, reaching out to people, meeting people, getting people, to hear, why, Maryland, why didn't we have assisted outpatient treatment? I honestly, as a community psychiatrist, I knew about Kendra's law, in New York, which was really the first AOT, but I didn't know it was assisted outpatient treatment. So I realized that if I was going to make some change with this population that I was really concerned about, that I was going to have to do something. And that really started me on that advocacy journey. And then fortunately, we did have in 2024, finally passage of this bill, which we can talk about as well.
Were you able to interact with any other stakeholders? Was that part of the work you did?
That was absolutely part of it. And I remember one of my mentors here, Ken Stoller, who I had reached out to find out, okay, what can I do? And he said, what you really have to do is start getting yourself involved in some of the state committees, like with Maryland Department of Health and BHSB, some of our kind of local core agencies. And he said, whenever you're invited to these programs, whenever there's a chance to ask questions, you need to raise your hand, ask questions, and start talking about AOT. Because what I realized, I gave a grand rounds here at Hopkins when I started realizing, okay, there is a problem here. These patients, I think, do we need to rethink state hospitalization? And it was during that research that I came across the fact that, okay, no, maybe it's not the state hospitals, maybe it's this assisted outpatient treatment. I realized that Maryland we were one of only 3 states in the country that did not have it. Not that everyone does it well, but I was of the impression that New York had it, California had it, and most people didn't, but we were really one of 3 states that did not have it. So once I started talking about it, I realized that there wasn't a lot of good feedback sometimes. And I started realizing that not everyone was as kind of gung-ho about, or kind of realizing that we really needed something like this for our patients. So once I started speaking out more at these meetings, I started meeting family advocates. I started talking with other community psychiatrists or capitation program directors or ACT team psychiatrists, state hospital, who really in that community space kind of were more aware of this population that they were seeing as well. And I will say too that Dr. Elias Shaya at MedStar, Sarah Van Rimmen, who was at Maryland, and Rishi Gautam, who was at LifeBridge, they were all in the emergency room, as well, seeing a lot of the same patients. And so we kind of formed a group where we were discussing these patients with unmet needs. And we realized that we needed to do more and really, kind of meet up with the family advocates, lend our voice with the state. It was interesting though, too, that I realized that some of the people who I thought would be on the, side of wanting something like AOT, some of these, organizations actually were at the opposition table. So it really required us to really understand, okay, why is there opposition? Even within our psychiatric society, there was some opposition. And so we really had to kind of meet in the middle and figure out how can we learn why is there opposition? Why are we proposing? And somewhere, because our patients are really the ones failing and dying early deaths, somehow we need to get to a place where we can compromise and kind of meet each other and do what we think is best for the patients. So it required a lot of outreach.
It seems to me in Maryland, both with respect to the AOT law and with respect to the definition of dangerousness, there's a very, very strong opposition comes from kind of the civil liberties contingent, and more so than I think in other states. And it seems to me that they sort of they don't understand the concept of risk benefit, that even though there's certainly the hazard, if you will, of depriving people of their liberty, the benefit might outweigh that. And having seen some of the testimony and related issues, that seems to be a very, very vocal, contingent. Is that your experience as well?
That was absolutely my experience. I really thought, even coming into my first NPS legislative committee meeting, and I came really because I said, okay, I'm here. I want to see where we are with AOT. Let's kind of champion this. And even when I brought it up, I could tell there was some little consternation within the group. And a lot of it really was the autonomy. Patients should have the right to choose if they want treatment or not. There was also this concern about racial disparities and that AOT was being applied to, disproportionately to minority groups or people who are, marginalized. But there was also a lack of recognition for anosognosia, which is that's got a controversial apparent connotation as well. But really, a lot of these patients that I see in the emergency department, and most of it is that there's such a severe lack of insight or anosognosia where they don't appreciate they're ill, that they don't appreciate that they need treatment. And although, yes, people should have the right to be able to make their own decisions and decide if they want treatment, we had to really help people to understand that this is a very small population where it's not just not wanting treatment because you're safe and you just don't want to be on medication and all that. This is the population that's actually dying early deaths, that they're being put out from their families, living, lives that they should be living better lives. So we really had to look at mainly that autonomy and help people to understand that there's a balance. And I often had to say when I was, giving testimony that, a lot of people at the opposition table they thought they were advocating for these patients, which I think they were. And I think they were advocating a lot of the lived experience. People had their own experience with involuntary certification, but a lot of them were high functioning, attorneys. And we had to kind of help them to understand that it's one thing if you were committed and it was inappropriate, we didn't want to minimize. But this is a population where, again, these aren't people who are living alone and working jobs and, have their, capacity to make these decisions. These are a lot of patients who really are lacking that insight and that capacity. And we had to really, I have started saying, I need to be an advocate for those who can't advocate. And, I felt like although you're advocating, I'm not sure what we're advocating for. We're advocating for people to have their rights on, even though they're dying.
It's true. This and also with the dangerous definition is that the people that represent, at least the public defenders who represent them, they tend to represent what the patient wants and not necessarily what's in their best interest. And I think that's so you're drawing sort of that distinction very effectively.
Yeah, the
So,
public defenders, they were one of the, when I, over the years, the first year when I, became, I think it was 2022, and it was still COVID where things were online. And I observed the AOT hearing, and it was about 15 minutes. And there were no physicians at the table, in support. There was a lot of opposition. 15 minutes went by. Everyone picked up their briefcases and left. And then here I am still losing, patients. And so then the next year I provided oral and written testimony. We did have luckily we had the backing of our legislative committee. We provided letters of support. But it finally got out of the House that year. The next year we realized we needed to increase, and we did have Dr. Shaya, myself, Dr. Van Rimmen, and Dr. Gotham. We had the Secretary of Health, who I chased down one time to make her aware that AOT is a must. But every year we really realized, okay, we got to increase our presence here. We have to have a louder, megaphone at the table. And again, I was surprised when it really did pass in 2024, but I felt like I wasn't going to rest until AOT passed, because it was really devastating watching patients just cycle in and out and not get better. And we were I was able to touch base with our carve out plan and spending hundreds of thousands of dollars on these patients who aren't getting well. So
before we move on to the current work of the committee and the workings of the committee, just wondering what was your sense of how the legislators themselves, the senators and the delegates, responded to these arguments, both your argument and the argument from the civil liberties contingent?
It was interesting because I really likened everything to kind of the mask mandates. When COVID was happening, there were people who really thought people had the right to not wear masks, and you had people giving information, not really speaking about the medical implications of how masks were saving lives. And so I really felt like the legislators were there and they were listening to whoever would come in front of them. And, it seemed like the people at the opposition table, the information they were given, I would listen to some of it, and some of it was really misinformation, and some of it wasn't correct, but there was no one to really challenge it. And I felt like once we started getting physicians at the table, and once we started giving them some data and evidence-based facts, and was able to challenge some of the things that were said, I felt like they appreciated it. I felt like they wanted to make good, informed decisions. And I think once we had physicians at the table being able to give them that medical piece, I felt they were able to then come out on the other side and eventually make a good decision and defeat the opposition that was really kind of allowing this to fail for 20 years. So I think they want that. And what I've told other people who have other, ideas that they want to champion or things that they want to do, that you really do have to get in front of them. They're, like you said, we see so many pieces of legislation that come before us. And I'm not an expert in many things. I do like community work and AOT and chronic mental illness and all, but I'm not a child and adolescent psychiatrist. I'm not a forensic psychiatrist. And I really believe that with a lot of the bills that we review, that the more we're able to really get ourselves at the table in these different areas, that we will probably have a lot more improved outcomes, because I do think they crave the expertise, the scientific knowledge, and want to make good informed decisions.
We move on to the committee. Why don't you tell us about the nuts and bolts of the committee and some of the things we've been working on?
Yeah. Well, I will say, I got elevated to this co-chair role, I think after the AOT bill passed, but I am a novice. And I remember Dr. Ann Hansen, who is, she was the chair for years. I know you, Dr. Israel, are someone who I look up to as an expert and someone who is very knowledgeable. When I was asked to co-chair, it was when Ann was stepping down and Michael Young had taken over. He was the co-chair for a while. And I said, when I was asked to do it, I said, I can't do it. I said, I feel like I don't know enough. But luckily they kind of took my hand and said, no, it'll be okay. So this year, actually, Brandon Newsom is on here. He's going to be the co-chair with me this year. But only because we agreed that yourself and Dr. Hansen and Dr. Young and Dr. Means we're going to all kind of do this together. So, I know Washington Psychiatric Society does, I think they meet all year, but, we meet on Wednesdays during January to around April, from like 7 to about 9, depending on how many bills we have. We have our lobbyists and our team. They look at the bills that are relevant to what our mental health platform, and they will say, hey, here's bills. So we look at the bill. What we try to do, and what I'm going to hope that we do moving forward too, is that people who are more expert in certain areas, that they, we try to get them to really look at, this is the bill in your area. Can you comment on it, look at it, see what your thoughts are? And so then when we have our meeting, we will go between the bills and just say, do we want to support this bill? Do we think we should oppose it? Should we support with amendments? We then decide, we find out if there's going to be hearings coming up. We then say, is anyone going to be able to go provide in-person testimony? We often do provide written testimony for the bills that we really want to either champion or make sure that we oppose. But it's really when we're there in person that I think we have the most impact. We have our legislative days where we pick a day to go to Annapolis and meet with the different members from the House and the Senate, and we pick a couple of bills that we're really wanting to focus on, and we really help them, try to get their support and give them our cards and try to educate them about those bills. But when it's time, I guess it's February to March, the hearings are coming up, there's in the House and it's the Senate, they've got to cross. There's a lot of, legalities that happen to just make a bill. So, we are fortunate that we have a lot of people who are dedicated, and they will come and say, I'll testify for this bill, or I will provide written. And then the hope is that we've made enough of an impact where, our goals are met. But it's interesting. You're aware that a lot of times, like the AOT, that took a while for us to kind of get on the supporting side. And then it took about 3 years for it to go through. And there are several bills that, we've discussed that each year we kind of build on it, and we say, okay, how can we learn from why didn't it pass last year? What can we do this year to make it different or better? And then, next, sometimes we might be more successful. But it's a village. I know this year with us kind of taking the lead, we're going to need, and you helped us with the dangerous bill with when we wanted to do amendments. It's not simply just writing things. I mean, there is an art to that. And so we really need our experts and our people who've been there way longer than me, who know how this works, because there's a lot of things that you learn through the years. And I'm looking forward to kind of growing in this space, but it truly takes a village.
I've always been impressed that the committee has a lot, just a real lot of wisdom and a lot of expertise. And I think that the discussions that take place are really, analyze things to their deepest levels and all the implications. And so I've been very impressed. And I've also really appreciated how on the discussion board, because the discussion takes place all week. The bills drop every day. We're encouraged to look at the board as the bills drop day by day, and people write very, sometimes they spout off a little bit, let's face it. But I mean, other times there's very, very long and thoughtful comments that make the board before we even have the meeting. So there's a general gestalt of where people stand once the meeting starts. So it's a very, very effective, and I know that it's been refined over the years. I have nothing but admiration for it,
Agree. And it's nice that we can go back to the different years and just see what we talked about. Like even now we can log on and see, well, how do we view this similar bill like in 2022 or 2023? And we can really have all the data there and everyone's comments, which is really nice.
Mm-hmm. Do you want to take a few minutes and go over some of the bills that are we running out of time, do you think? Right.
You know what? I think we can just talk about, a couple of the ones that some did pass this year. And I think the dangerousness bill actually passed. And I'm glad it did, because now that assisted outpatient treatment, which will go live come July, that's we're going to need an expansion of the dangerousness bill to make sure that our patients who might need to be hospitalized can actually stay longer than what they would if it was just the imminent danger part, because
Right.
a lot of these patients are going to need longer hospitalizations and going to be need to be able to be kept longer. And with the expansion of the grave disability, that's where what changed is that now the law is going to allow the thought that if someone's unable to care for themselves because and they're unable to adequately clothe or feed themselves, then we can say that hey, that's meeting criteria for dangerousness, as opposed to more of the thought of the imminent danger. So I was glad to see that pass this year, and I think it's going to be go hand in hand. It comes, I think, in October is when that will when that'll happen. Also, we realized with the AOT bill that we did not have a provision for taking firearms. And it's interesting because even though the AOT bill passed, this has now been the second year where we've not been able to get that firearm provision passed. And it's interesting because a lot of the advocates that I met along the way and a lot of the people who were working to get AOT passed, they're not really wanting to see the firearm restriction per se, because they're worried that it adds a criminal kind of component, which we're trying to help people to understand. No, it's not a criminal component, but we know that there's increased suicide risk in this population, and we know that their access to firearms are increasing that risk. So again, more collaboration. I'm hoping next year, I think we got more of the advocates to understand where we were coming from this year, and I think next year we just need to collaborate more to hopefully get that passed. One of the ones that was popular this year that the APA put a lot of resources in was the psychologist prescribing bill. Fortunately, that did fail. And I think we learned that there's about 7 states that do allow for psychologists to prescribe. And some of the bills we were coming upon this year was really increasing that scope. PAs wanting to do what psychiatrists do. Psychologists wanting to prescribe. There's a lot of kind of mission creep and scope bills, but fortunately that psychologist prescribing bill did not pass. And the APA really helped us with the talking points and the data. We were able to kind of offset some of the misinformation that was given. I know there are one that did come up that we were hoping would pass, but it failed, was the medication panel reviews for the patients who are incarcerated waiting to be transferred because they're incompetent. Right now, patients can be in the central booking or the jails because they can't get into the state hospitals to get treated. And if they refuse treatment, they can refuse until they're in the state hospital. And this bill, which Dr. Hansen was championing, and she went before the committees to talk about the need to be able to do med panels in the jails, just like they do in the inpatient unit, so that patients who are there and ill and not getting better can't be for months. They're, unmedicated and just deteriorating, which we know it's going to decrease their ability to get better later. So I think we have an opportunity next year to be a little bit more aggressive and to, try to hopefully get that bill passed. That's just some of it.
So I think they're reaching a compromise. But you're right, because people are there, they're stuck there. The position of the opposition has been, well, if they need a treatment, they should go to a hospital. But in fact, staffing isn't all that different between the places, but there's no mechanism to medicate over objection. So that's that's a thing.
Right.
Yeah. Okay.
Yeah. So there's a lot of them, but those were some of them. I'm trying to.
Well, one I think that just from the insurance and sort of finance point of view, a couple of bills are relevant to that. One is there's a bill that says that anybody that prior authorization for medication cannot be required for patients that have schizophrenia, depression, PTSD, or bipolar disorder. Mm-hmm. And that one was dead on arrival in the. But it's interesting that other states seem to have similar provisions and somehow, the states don't go bankrupt, allowing the pay, because as we know, psychiatric patients are much more vulnerable to disruption. They have, often have idiosyncratic attachments to medication. So if they're sort of told from without, you can lose the patient to treatment. So I think that working groups are going on to try and come up with some compromise there too. I'm involved in that, and so we'll find out more about that next time. The other thing that's interesting is that there was a bill that would require managed care companies to report to the state the the number of patients that were forced to go out of network for treatment, whether their directories are accurate, whether they're adequate to fill the need relative to other specialties, and that actually failed in the house in the so I don't know
Mhm.
why that is, but I do think that we have to be aware of the enemy that we're up against, because they put a lot of money and a lot of effort into getting their point across and to raising the boogeyman of we're gonna spend ourselves into bankruptcy, and don't see that there's a real benefit to society when when some of these measures are passed. So
Great.
it's so that's a couple other things to keep in mind. But we're running out of time. I just wonder if there are any questions from the audience that someone would
Looks
like
like
to.
there's a question in the chat.
Oh, well, let's see.
I think from Bruce Taylor.
Oh, sure. Go ahead. Have Dr. Taylor.
Thank you. Thank you very much. Appreciate all the hard work everybody does throughout the year. Some of you may know that for a number of years I've worked to try to get universal health care in Maryland, and failed miserably about 10 years ago when I got a bill passed that got watered down to a study group on which I was the only physician. So anyway, I'm trying a new, more gradual approach now and hope to have the support of MedChi, WPS, and MPS, and have a meeting set to meet with Gene Ransom towards the end of next month. And Dr. Rick Taylor, my cousin, who's a neurologist, and Dr. Elias Shaya have both agreed to help participate in this. And the goal is to get not universal insurance, but universal secure online records for all patients, to include all medicines for all patients, to include benefits that are available for all patients, and then ideally also online electronic payments for all patient services. So that would form the backbone for ultimately a universal health care if and when we could ever get it. But in the meantime, in theory, it should, if put in place, improve the workplace situation for all physicians, not just psychiatrists, and improve job satisfaction and increase access for patients. So, you know, when I see patients who are new, I ask them to bring all their medicines in a paper bag, you know, shopping bag, whatever it takes, because they can't remember what they are, and you know, have a blue pill, have a red pill, whatever. So you all are probably familiar with that, but CRISP does a great job and does meet some of these goals now, but I think they would be the logical organization to get additional funding to expand this role, because you know there's a limited number of patients and institutions and physicians who participate in the online records with CRISP. So I wanted to make people aware of that, and hope that through your individual legislative advocacy groups that when this comes up next year, you would help support it, and that if there are members in each group that would like to be more involved, to please contact me.
That sounds great. That's great.
Any other questions or comments? Okay. Well, let's call it a night then. Thanks everybody for coming. And if you have sparked anybody's interest, you know, to join the either committee or get involved in some other way, drop us a line. So good night, everyone. Have a good rest of the night.